I'm Dr. Fakiroveri, and this is Invasive Fungal Infections in Adults. Fungal infections have an enormous impact on human health. There has been a significant increase in the incidence of fungal infections worldwide, primarily due to advances in organ and bone marrow transplantation, cytotoxic chemotherapy, widespread use of indwelling IV catheter, and increased use of potent broad-spectrum antibiotics. Fungi are eukaryotes, so they do have a nucleus inside the cell, and they have many organelles known in eukaryotes, including endoplasmic reticulum, mitochondria, and Golgi apparatus. But one main difference between the fungi cell and other eukaryotes such as humans is that instead of cholesterol in the cell membrane, they have ergosterol, which is a target of some antifungal agents. Now, fungi also have rigid cell walls that are composed of chitin, cellulose, or both, and those can actually be stained in addition to gram stain. So there are specialized stains for fungal agents or organisms. Most fungi, except for Candida species, are too weakly gram positive to be seen on a gram stain. So that's why we need specialized dyes for staining. Now let's take a look at clinically important fungi. In general, fungi can be divided into yeasts, molds, and dimorphic. Candida and Cryptococcus species are yeasts that commonly cause fungal infections in susceptible hosts. Now, yeasts are typically round or oval. They generally form smooth, flat colonies, and they reproduce by budding. Now, Candida exist in 3 biological phases. So yeast in the yeast form, they can also exist in pseudohyphae as well as hyphae. Now, when they are in the hyphae form, they can cause tissue damage by invading mucosal epithelial cells, and then they can lead to blood infections. Now, molds are also composed of tubular structures called hyphae, but they grow by branching and longitudinal extension, and their colonies typically appear fuzzy. Now, conidium, or conidia is the plural form, is an asexual spore usually produced at the tip or side of a hypha, and that's important in spreading this mold around. Now, the common molds that cause fungal infections include Aspergillus, Fusarium, and Mucorales. Mucorales and Fusarium are less common, but they are much more resistant to antifungal agents, and the mortality rate in these infections are extremely high. And lastly, we have dimorphic fungi, and these can actually grow as both mold and yeast. So they basically exist or behave like molds. So they look filamentous, and they behave like mold at room temperature, but at body temperature, they actually behave like yeasts. And that's why they are called dimorphic. Now, these species include coccidioides that can cause cocci or valley fever. There's also blastomyces that cause blastomycosis, and histoplasma, which can cause histoplasmosis. And these are essentially called endemic fungal infections, meaning that they are only in certain geographic regions. For example, Central California is known for being endemic to cocci. Here are some reliable resources. So IDSA guidelines have several guidelines for fungal infections. Most common ones include the 2016 guidelines for management of candidiasis. So these are any infections caused by Candida species. There are also 2016 guidelines for diagnosis and management of aspergillosis. And there's also a joint guideline between IDSA and ASCO for antimicrobial prophylaxis for adult patients with cancer-related immunosuppression that include antibiotics as well as antifungal prophylaxis. Another guideline is the 2016 IDSA guideline for coccidioidomycosis. And there are a few other older guidelines. So there's the 2010 guideline for cryptococcal disease. Now, cryptococcal disease, because they're also very common in patients with HIV, there are also HIV guidelines for opportunistic infections that cover cryptococcal disease, and those are updated more frequently. But IDSA guidelines are actually from 2010. And there are older guidelines, 2008 for blastomycosis and 2007 guidelines for histoplasmosis. The first learning objective is describe the pharmacokinetic, pharmacodynamic, and toxicodynamic properties of antifungal agents. Here's an overview of how various antifungal agents work. So we have agents that actually go all the way into the nucleus of the fungal cell and prevent DNA and RNA synthesis. We have agents that work on the cell wall, including agents that prevent the synthesis of ergosterol. That's essential for the cell membrane. There are agents that actually cause a pore inside the cell membrane and cause wasting of various electrolytes and leading to cell death. And we have agents that prevent synthesis of beta-glucan, which is also important in the cell membrane. And they are important in the structure of the cell wall. So beta-glucans are components of the cell wall. Now, the first class of antifungal agents are azoles, or more specifically triazoles, and they essentially inhibit synthesis of ergosterol by blocking 14-alpha demethylase, which is essentially a CYP enzyme. So this is CYP51 in the fungal cell, and these agents act by inhibiting this enzyme. So one way that resistance can occur in fungal species is primarily through increased production of this enzyme, which is a product of ERG11 gene. They can also cause alterations in the binding site on this CYP enzyme. And of course, there can also be drug efflux pumps that will pump the azoles out of the fungal cell. So what normally happens is that this ERG11 gene leads to the formation of CYP51 enzyme, which leads to synthesis of ergosterol, which is important for cell membrane. When you have azoles, they essentially block this process, so the cell membrane will not have these ergosterol, which results in cell wall inhibition. Now let's take a look at each azole one by one. So the first one is fluconazole. Fluconazole is available as PO and IV, for systemic infections. Of course, also available in other formulations, but for invasive fungal infections, we're interested in IV and PO. They can be taken without regard to food. In general, fluconazole is extremely safe. Very little toxicity. Patients may experience some headache, but in general, very well tolerated. And the hepatotoxicity essentially means that this fluconazole can lead to transaminitis. So maybe AST and ALT will be elevated, but in general, very well tolerated. Now, with long-term use, so if people are taking it for months or perhaps for indefinite duration of therapy, they can experience some other adverse effects, including cirrhosis and alopecia. But for acute use of fluconazole, these are extremely rare, or in fact, they may not occur. Now, one thing of note is that all azoles, in one way or another, they affect QTc. So it's important to have EKG on board if they are to be used long term. So fluconazole does prolong QTC, and also one must consider other agents that the patient might be taking that can lead to QTC prolongation. The next agent is itraconazole. So itraconazole is not available as IV. There used to be an IV formulation that's been taken off the market due to concerns for congestive heart failure. In fact, this black box warning is specifically from the IV formulation. But with the oral formulation, there is a capsule and there is a solution. In general, with the older formulation, because there is a new formulation called SUBA-itraconazole, and SUBA essentially supra bioavailable, so they increase the bioavailability in this formulation. So this one is relatively new and therefore more expensive. So the more affordable one is the older formulation, which had limited bioavailability. So between the capsule and solution, the solution must be on empty stomach, but the capsule with food. And the solution actually has much better bioavailability. So most people actually use the solution, and patients have to take it on empty stomach. Now, the new formulation is promising, but it's relatively new, so it's kind of expensive right now. But in time, this will likely overcome the limitations of bioavailability, because it's really difficult to have patients. If you are to dose this twice a day, it's difficult to have empty stomach twice a day. Especially in the evening, it becomes very challenging for patients. Now, relative to fluconazole, there are more adverse effects with itraconazole. So hepatotoxicity is still there, so perhaps increased ASD, ALT, and some GI effects, but also itraconazole associated with hypertension, hypokalemia. So the potassium levels should be monitored, and some patients may need to be on potassium supplementation to manage this hypokalemia. And it can also lead to peripheral edema, so those are important to monitor. And of course, it's important if the patient also has heart failure. It's not a contraindication, but it's important to monitor the patient closely. Now, the mechanism behind pretty much all of these hypertension, hypokalemia, and peripheral edema is that essentially itraconazole can lead to mineralocorticoid excess. So as a result, there will be hypokalemia and fluid retention. Now, it can also lead to QTC prolongation. Next, we have voriconazole. Voriconazole is the one with the most adverse effect, and it is available as PO and IV. The PO formulation must be taken somewhat on empty stomach, essentially 1 hour before or after food, so it doesn't have to be completely empty stomach. And here are the adverse effects. So hepatotoxicity is much more significant with voriconazole. It can also lead to neurotoxicity, specifically reversible ocular toxicity such as photopsia, photophobia, and color changes. It can also lead to rash and photosensitivity, and with long-term use, this similar to fluconazole can lead to cirrhosis and alopecia, and it also causes significant prolongation of QTC. Now, post-antifungal is available as PO and IV, but the oral formulation, the tablet specifically, has excellent bioavailability, so much that solution is hardly used anymore. The solution one did need to be taken with food, but the tablet doesn't have to be. So the tablet can be taken with or without food, but excellent bioavailability. And the adverse effects are much better tolerated. So this is kind of similar to itraconazole. So it does have GI adverse effects and transaminitis. And similar to itraconazole, it can lead to hypokalemia, hypertension, and peripheral edema through the same mechanism. Now, interestingly, post-antifungal might not change the QTC. Now, some sources have cited that it may increase or prolong QTC but a lot of sources also mention that there is no change. So it really depends on the person, but most likely post-antifungal does not change QTc. And the newest azole is isavuconazole or isavuconazonium sulfate, which is a prodrug, but it's available at PO and IV. It can be with or without food, and it's very well tolerated. So some GI adverse effects and the mechanism for hypokalemia is still there. Now, interestingly, isavuconazole can actually shorten QTc, so it's actually the opposite of the rest of azoles, but much better tolerated. Now, when you go from fluconazole all the way to isavuconazole, the price goes up because these are the newest agents. So fluconazole, itraconazole, pretty affordable. SUBA-itraconazole is very new, so this is very expensive. Voriconazole is somewhat affordable, but still kind of expensive. But post-antifungal and isavuconazole are very, very expensive. Now let's take a look at PK/PD of triazoles. Fluconazole, one of the oldest triazole, is the only triazole with excellent urine penetration. So anytime you have candiduria, fluconazole is the agent of choice for urinary infections. Because of its low protein binding, it also has excellent CSF penetration. In fact, when you look at all of the triazoles, most of them have high protein binding. Fluconazole has the lowest one, so it has excellent CSF penetration. Voriconazole is also, because compared to the other ones, has lower protein binding, also has good CSF penetration. When it comes to drug interaction, fluconazole is not the biggest interacting triazole. It's not the substrate of any of the CYP enzymes, and it has moderate inhibition of CYP enzymes. So although it can affect some of the drugs, in general, it doesn't cause a lot of drug-drug interactions. It does have a long half-life of about 30 hours. So it does take some time to get to a steady state, but then levels stay pretty steady. Now, because fluconazole is highly bioavailable and there is not much variability between patients, therapeutic drug monitoring or TDM is not indicated. Now, for all triazole, pretty much PK/PD target is AUC to MIC. They happen to be fungistatic for Candida species, but they are fungicidal for Aspergillosis. So because we don't do TDM, a trough target is unclear, and we don't really do TDM, and it's in general very well tolerated. Fluconazole is very well tolerated, so there isn't any toxicity target. For itraconazole, which has a non-linear pharmacokinetic properties, therapeutic drug monitoring might be helpful in certain situations, for example, in transplant patients. And especially with sporanox that is not as well absorbed and there is a lot of variability between patients, so therapeutic drug monitoring might be indicated. And although the AUC to MIC target has not really been established for itraconazole, when it comes to TDM, it is recommended to have a trough of 0.5 for prophylaxis, and for treatment it is a trough of at least 1. Now, for the most part, when people do therapeutic drug monitoring for itraconazole, it's a matter of do we have enough concentration. So for a lot of patients, we actually have subtherapeutic concentration. So it's a matter of do we need to increase the dose. And when it comes to toxicity, there is a large ceiling. So essentially, you have to go up to level of 17 to get toxicities. So in general, it's pretty well tolerated. So you have a large window. So it's very difficult for patients to get to that level. Now, with voriconazole, it's the opposite. So because toxicities are very serious and also the threshold for toxicity is pretty low at 4.5, therapeutic drug monitoring is indicated for anybody who's taking voriconazole. Not only does it have a lot of drug interactions because it is a substrate of 2C19 and 2C9, but also inhibits 3A4 and P-glycoprotein. Now the problem with voriconazole having nonlinear, as well as with itraconazole having nonlinear pharmacokinetics, is that the dose adjustment based on the levels is not straightforward. So for example, doubling the dose doesn't necessarily double the serum concentrations. So essentially you would have to increase or decrease the dose in increments, and just go on a patient by patient cases. So for voriconazole, a trough of 1 to 3 is indicated for treatment. SIDP specifically recommends a trough of 1 to 2, but other sources says 1 to 3. And for prophylaxis, it's at least a trough of 0.5. And of course, we want to keep it to less than 4.5. Some sources say it might be even better to keep the trough under 3.5 to avoid toxicity. For post-antifungal, we have a formulation that's delayed release tablet with excellent bioavailability, whereas the solution has more variability between patients. So for that reason, therapeutic drug monitoring might be helpful in certain situations, and that depends on the formulation. So again, the delayed release tablet has excellent bioavailability. And last but not least, isavuconazole has excellent bioavailability as oral formulation, and therefore therapeutic drug monitoring is not indicated. And of course, a target trough has not been established. Also, it is very well tolerated, so also a toxicity target has not been established for isavuconazole. One more thing to consider about itraconazole specifically, depending on the lab, when they measure trough levels, because itraconazole has an active metabolite, so hydroxyitraconazole, some hospitals actually combine the itraconazole level plus the hydroxyitraconazole and measure the total concentration, just because hydroxyitraconazole has activity. However, these targets are specifically for the itraconazole levels, not the metabolite. The next class of antifungals are echinocandins. So these actually bind to the FKS catalytic subunit of the 1,3-beta-D-glucan synthase. So this is an important enzyme. And by doing that, it inhibits the 1,3-beta-D-glucan synthesis, which is an essential component of the cell wall of many fungal species, with the exception of Cryptococcus species. So Cryptococcus species do not have or don't have significant amount of 1,3-beta-D-glucan. In fact, Cryptococcus species mostly rely on the 1,6-beta-D-glucan, and that's so these agents will not really inhibit 1,6-beta-D-glucan. So for that reason, this class will not be active against Cryptococcus species. But for Candida and Aspergillus, which are the most common, they are very good agents. Now, mutations in the hotspots of FKS gene result in resistance to echinocandins in Candida glabrata specifically. And let's look at the pharmacokinetics of these agents. So there are 3 of these on the market right now, and there is one under development. So caspofungin was the first one. These are all IV, so we don't have any oral formulation in this class. In general, they are really, really well tolerated. So there's not much adverse effects that would lead to discontinuation. Of note, pretty much none of them get good concentration in the urine, so they're really not good for urinary infections. And they're also not good for any CSF infections. And, in general, they don't really cause any drug-drug interaction. So for that reason, they're also very, friendly. and their half-life in general is moderate, but the newest agent that's under development has a very long half-life, so that one is intended to be like weekly injections, whereas the rest of them are daily, once a day injections. And because they're all IV and there's not much variation between the patients because they're not really major substrates of CYP enzymes, so its therapeutic drug monitoring is not indicated. Rezafungin was approved in 2023, and because of its very long half-life, it can be dosed at weekly intervals. Now, the next class is flucytosine. So flucytosine actually must first be taken up by fungal cells by the energy-dependent transporter cytosine permease. And then once in the fungal cytoplasm, flucytosine is readily deaminated to a 5-fluorouracil by cytosine deaminase. And then following conversion to fluorouracil, its antifungal effects are mediated through inhibition of both DNA and protein synthesis. So mutations affecting cytosine permease, cytosine deaminase, and UPRT activity, can lead to pretty much resistance to this agent. And because there's so many targets for mutations leading to resistance, this agent should never be used as monotherapy. So anytime you see flucytosine, it will be bundled with another antifungal agent for most fungal infections. Now, lastly, we have amphotericin B. So amphotericin B works by insertion into the fungal cytoplasmic membrane by binding to ergosterol and forming pores that result in the loss of intracellular potassium, calcium, and magnesium, which can cause cell death. Now, in addition, amphotericin can also induce oxidative stress. So these are all good for killing fungal cells, but these are also key in a lot of the adverse effects that are associated with amphotericin B. So including, all of these electrolyte wasting. This can also happen to the kidneys, so a lot of nephrotoxicity from amphotericin B. So the affinity for sterol is kind of similar to affinity of amphotericin B for cholesterol. So it can also bind to cholesterol inside the mammalian cell membrane. So it can pretty much have those effects on those cells too, which can lead to not just nephrotoxicity. It happens to be in the heart. It can cause cardiotoxicity, and it can also lead to anemia. Now, resistance to amphotericin B can be due to reduction in synthesis of ergosterol, so that way there's not much binding site for amphotericin B. Now, there are different formulations. So the classic one is the amphotericin B deoxycholate, which is essentially the smallest molecule, which is here on the left. It's less than 25 nanometer. But then in order to improve tolerability and reduce all those nephrotoxicity issues, there are lipid formulations. So essentially these have been in various forms been turned into lipid formulation. So we do have liposomal amphotericin B, which is much larger molecule, so it's less than 100 nanometer. And then we have amphotericin B lipid complex, which is kind of like a chain, and it can be very large. So this is somewhere between 1600 to 11,000 nanometers in size. So let's take a look at the different amphotericin B. So currently there are 3 that are on the market. There used to be a 4th one on the market, currently not available, but we'll focus on the 3 that are on the market. So the classic one, the conventional amphotericin B, is deoxycholate, and so all of them are IV, no oral formulation for amphotericin B. So the conventional causes severe nephrotoxicity, including wasting of potassium, magnesium, and bicarb. So and as well as, because this is in the kidneys, it can reduce epogen production that can lead to anemia. There's also a lot of infusion reactions. Now, because of all this nephrotoxicity, it's important to provide saline loading to the patients. So in other words, patients receive 1 liter of normal saline before amphotericin has been initiated in order to reduce nephrotoxicity. Now, in general, they have poor penetration into the urine through IV injection, and therapeutic drug monitoring is not indicated for any amphotericin B formulation. And also, let's talk about flucytosine. So flucytosine is only available PO. It has a very short half-life, and it is dependent on renal function. So this is very highly concentrated into the urine, and so renal function is really important because this drug can also have severe adverse effects, including myelosuppression, so neutropenia and thrombocytopenia. So renal function must be monitored closely because typically this is given 4 times a day, but as renal function deteriorates, the dose needs to be adjusted. So because of the serious adverse effects of myelosuppression, therapeutic drug monitoring is indicated. So for efficacy is the trough that's important. So the trough needs to be at least 25 for efficacy, but for the toxicity is the peak that makes a difference. So we want the peak to be under 100. Once you go over 100, the risk of myelosuppression goes up significantly. Now, lastly, let's take a look at the spectrum of activity of these agents. So it's good to think of yeasts and then molds and then dimorphics. So when it comes to yeast, these are the significant candida species that cause fungal infections, clinically important. And there's also cryptococcus. So pretty much amphotericin B has very good activity against most of these, except it doesn't have good activity against Candida lusitaniae, which is historically. Some reports say that it actually might have activity against lusitaniae, but most sources, and especially classically, we say that amphotericin B is inactive against lusitaniae. And most recently, there's been an emergence of Candida auris, and and these species may or may not be resistant to amphotericin B. So there just needs to be susceptibility testing to find out. Now, for fluconazole, pretty much good activity for Candida albicans, but MICs are much higher for glabrata. So susceptibility must be checked, and in fact fluconazole might have to be given at higher doses depending on the MIC of glabrata if it's susceptible dose dependent. And then there is just not activity against crucii, and of course auris is pretty much resistant to fluconazole. Now itraconazole is pretty much good activity against albicans, but not active against glabrata, and has somewhat activity against parapsilosis and tropicalis, but susceptibility is needed. Also not active against crucii, and of course for Candida auris, you just need susceptibility results. Now, when it comes to voriconazole, this is when you get broad spectrum. Pretty much voriconazole has good activity across all yeasts, with the exception of auris that may or may not be susceptible. The same with post-antifungal and asavuconazole. So these three are pretty much broad spectrum antifungal agents, and so when it comes to yeast, they're pretty similar. Now, when you go to echinocandins probably have superior activity against yeast compared to azoles. So pretty much more, they cover all of these yeasts, including Candida auris. So pretty good activity against Candida auris. But the shortcoming is that echinocandins are not active against cryptococcus. So no activity against cryptococcus. And flucytosine is yellow for pretty much most of these because it should not be used alone, so it should be used in combination with another agent, and it's just not active against cruci. Now next, let's take a look at molds. So then we have different Aspergillus species, and then we have the difficult molds like Mucorales and Fusarium. These are very nasty, resistant molds that cause a lot of mortality. So amphotericin B has good activity against most Aspergillus, but then it kind of becomes short when it comes to some of these other molds. Fluconazole has the worst activity, so that's why we would say fluconazole is narrower spectrum antifungal agent. Itraconazole has more activity, but again, it's not active against Mucorales or Fusarium. Voriconazole has somewhat activity against Fusarium, but definitely not against Mucorales. And then posaconazole and isavuconazole, that's when you get the activity against Mucorales. So when patients have Mucorales, these are essentially the agents that you want to use. And then for echinocandins, they have somewhat activity against most molds, specifically Aspergillus, but in general, their activity is not as good as azole for Aspergillus. It's the opposite of Candida. So echinocandins have better activity against Candida compared to azoles, but it's reverse for Aspergillus. So azoles are better against Aspergillus compared to echinocandins. And flucytosine just does not have activity against molds or dimorphics. The same can be said about echinocandins, no activity against dimorphics. So for dimorphics, we're really stuck with amphotericin B and azoles.